Thank you for joining us for Conversations in Hematology Oncology. During this segment, we will be discussing optimizing therapy with bispecific antibodies. I'm Dr. Kambhampati, Assistant Professor of Hematology at City of Hope, and I'm joined here by my colleagues, Dr. Salles from Memorial Sloan Kettering and Dr. Matthew Lunning from University of Nebraska. During this segment, we'll discuss the safety profile of bispecific antibodies, mitigation strategies to address toxicity concerns, biomarkers of resistance and toxicity, how to increase access to this therapy, as well as conclude the segment with a group discussion of a few clinical scenarios to illustrate approaches to management of patients. So with that, I'll start by asking you, Dr. Lunning, could you walk us through a little bit of the various toxicities and safety profile of bispecific antibodies that we've observed across the various pivotal trials?
Certainly. Thank you for that question. So, bispecific therapies were really studied in the generation of CAR T-cell therapies. And so it really got attached with its cytokine release syndrome, neurotoxicity, and that's how we assess the AEs in the clinical trials. And that's really how I think we've started to think about these appropriately or not appropriately. But when you think about cytokine release syndrome with each one of these bispecifics, they all have kind of different flavors, different times that the toxicities have the highest risk emerging, and differing risk mitigation strategies. For glofitamab specifically, there is a obinutuzumab lead-in therapy a week before. And even then, the highest risk for CRS is with that first dose of the glofitamab. In contrast, if you look at epcoritamab, which has no CD20 monoclonal antibody lead-in, the highest risk is with that step-up dosing with that third weekly dose at cycle 1, day 15. And I think, initially with the approval, it was strongly recommended that cycle 1, day 15 dose be delivered, and then the patient be monitored as an inpatient setting, hopefully with further data presented through clinical trials and better and more experience, we'll be able to get rid of that inpatient hospitalization. I think some of the other caveats is that epcoritamab comes with 3 days of prednisone or equivalents of prednisolone dosing for 3 days after the dosing of epcoritamab for the first month or the cycle 1. So when you start talking about toxicity and management strategies, in my mind, you have to ask the question first, is the CRS happening while the patient's on 100 milligrams of prednisone, let's say, or if it's not happening on steroids, as could happen with glofitamab versus epcoritamab. And so I still think we're in a little bit of a wild, wild west where we've learned a lot in clinical trials. We're now in the commercial environment. We're all trying to figure out, is it tocilizumab or is it 10 of dex or 12 of dex or 14 of dex? Obviously, I think it's probably going to come in multiples of 4 milligrams, in regards to the management of these patients. But I think, dipping your toe in the water, a lot of us have. Many of us have jumped 2 feet in, but we're all working through the toxicity management strategies.
Thank you for that, Dr. Lunning. And you touched upon some very important points, including the safety of the bispecific drugs and ways to potentially mitigate those toxicities. So, Dr. Salles, in addition to the cytokine release syndrome, what are some other toxicities that have been observed in the pivotal trials with bispecifics?
Yes, this is an important question. I mean, we focus on the CRS. There have been, as Dr. Lunning explained, a link between bispecific and CAR T, and there have been a couple of what I will call neurological events. Are they really like immune cell associated neurologic symptom? I don't know. Some of them were occurring when the time patients had fever, when the time patients were a little bit confused in heavily pretreated patients. But it looks like in a few patients, there is really a little bit of neurotoxicity, which is specific. It appears to me to be quite rare, but it exists. And, it's essentially managed with a little bit of steroids. I think we have a few patients, either during the first cycles or even later, like we have seen with rituximab, who have neutropenia, very rarely cytopenia. I think we'll have to pay attention to infections. And I think, we have B-cell depleting agents. We have already been submitted to the wave of the COVID infection. Probably it's over, but still, some viruses are still around, and maybe reactivation of some viruses, maybe reinfections, and we are probably triggering T cells several times during these repeated injections. And maybe what we have started to see are a couple of opportunistic infections. So in reality, most of these patients were heavily pretreated. Many have received CAR T transplant, have gone through several lines. So I will say it's difficult at this time to make a clear cut here. But let's pay attention besides the cytokine release syndrome to the other side effect. And as said, mitigation strategies, it's now mostly on steroids rather than tocilizumab, because this is so easy to manage besides the rules that were implemented in clinical trials.
Thank you so much for that, Dr. Salles. Dr. Lunning, would you be able to tell us a little bit about what biomarkers we have at this time to help us predict toxicity for patients and other strategies that you may be using to mitigate these toxicities?
Yeah, if I had that answer, I would be able to discern who could be inpatient and who could be outpatient with bispecifics. I think we're early sledding, and figuring out these biomarkers. I think you can come back to the principles, though, that we learned from CAR T cell, bulky disease, circulating disease, in particular, probably circulating disease or leukemic phase. And then really focusing in on the temporal nature of this. And I wouldn't forget that if a patient had a fever with cycle 1, day 8, there is a increased risk at subsequent cycles. And so I would continue to kind of be a very close eye on them until they don't have a cycle where they don't have, a fever or early phase or early grade CRS, because it can return. But short of that, I don't have a magic trifecta of tests that I can do to predict toxicity.
That's a very fair enough point. And Dr. Salles, can you tell us a little bit about what are biomarkers of response and resistance that we can that we have data on for bispecifics?
Well, I think it's interesting because for the time being, it looks like the majority of patients respond not depending on some specific characteristics. I mean, we have seen response in patients with large bulks. We have seen responses in double hit. We have seen patients in response in younger, older patients after CAR T, maybe a little bit less. So I think, we are working on that very deeply in biology, but, it's far from being clear what we will get from that. And I think much more to come in this field. There is one interesting thing, I mean, obviously not routine practice right now, is that there is an early response with very disappearance of circulating tumor DNA, really predicting the long-term efficacy of these drugs.
That's very true. And I think there's a lot more that we need to know to understand which patients may develop resistance and which patients may have long durable responses with this treatment. Dr. Lunning, what do you see as an access barrier for us in terms of getting this drug, these bispecifics, to the community and to allow more access to care for these treatments that are clearly very promising?
Yeah, I think it's not necessarily going to be the drug, but it may be just the cooperation in the community between a facility dosing the drug in a community infusion center, and then, them having to go to the regional hospital with potentially the need for tocilizumab availability. And that's why I think we need to kind of better explore, whether or not tocilizumab is the best agent, to treat the CRS, or whether or not CRS can be supported if they have grade 2, whether or not it can be cut off a little bit earlier with steroids. So I think we're still in the learning phase, and it's unfortunate because I would have hoped we were a little bit further along as we shepherded these drugs out into the community, because I think that's going to be the apprehension to utilize them that goes beyond kind of that interplay between community practices and regional hospitals. I think it will be overcome with time because this class of therapy is just too important to leave behind.
Absolutely.
If I may, I should add to that this is a teamwork. And, as physicians, obviously we order the drug, But if we have nurse practitioner, nurses able to call the patients the next day to monitor, to help them use the steroids, this helps. And it's a collaboration between the different stakeholders of the team to keep the patient engaged during this first cycle. And we have to train our teams in order to implement these drugs.
Absolutely.
So as they say, teamwork is the dream work. So absolutely agree. And then in terms of choosing between bispecific, let's say you have a patient with double hit lymphoma, DLBCL, primary refractory disease, and progressed on dosage of Zaripa, got second line axi-cel with a quick relapse post-CAR-T within a month. Which treatment approach would you choose out of the two bispecifics in this patient's, epcoritamab or glofitamab? And what is the reasoning for that choice? I'll start with Dr. Salles.
Well, this is, again, which one, epcoritamab, glofitamab? I don't think we have the right answer, and I will not necessarily jump. I think the response rate in post-CAR-T setting is similar. Probably a little bit, whether the response is a little bit more rapid with glofit versus epcor, which is subcutaneous. I don't know. I don't have that much, experience to say. Probably you can modulate a little bit, and because the escalation allows you to give the IV dose at different intervals. When the issue with epcor is if you stop for any side effect, in this particular very aggressive patient, you may want to restart, with a low dose. Here you will like to have pretty quick efficacy. Unfortunately, I will say the chance of having a durable response for this particular patient is low, but we should attempt, with our good surprises sometimes.
Absolutely. Any other thoughts on which one you use, Dr. Lunning?
I think this is, I really don't have a clear-cut answer. I kind of have drawn my line in the imaginary sand, just how I'm thinking about this. But I have more experience with epcoritamab in primary refractory, kind of no response CAR T-cell patients than I do with glofitamab. If I'm gonna take a primary refractory patient, I'm just not comfortable stopping a therapy that gets them into a CR. So if they're refractory, I'm probably going to do epco. If they're relapsed post-CAR T and they got to like 3 to 6 months, then I think glofitamab would be reasonable, because I would probably be willing to have the conversation about putting it on the shelf, looking at the durability, post-CAR T. But what's amazing to me in both clinical trials is the number of patients that didn't come off and go to allo transplant in CR. And I think that's really what's bothering me here is kind of, you have relapsed refractory large cell lymphoma after CAR T, and you get that cure carrot dangling in front of them because they get into a CR, which is, a lot of patients can't get to allo transplant because they don't get a CR. But very few patients, came off those trials to go to allo transplant. And it'll be very interesting to see if we're willing to not take those patients that go into CR in a commercial environment to an allo transplant if we do achieve that magical complete remission.
Maybe another word regarding fixed therapy. There have been limited cases, but some report of experience that even when you have stopped one antibody with fixed therapy in the occurrence of glofitamab, that the patient progresses a few months later, you can resume and it works in some patients. Again, limited experience, but it's not necessarily that you have, use your magic bullet and you cannot use it anymore.
That's absolutely a great point. I think we need more data in terms of durability of these responses, retreatment with bispecifics. And I think one important point is that in this case, the patient relapsed very quickly within 1 month of CAR-T, and these patients were often excluded from the pivotal bispecific studies. So we need more real-world data in our practice here, where we've taken these very heavily refractory patients who are progressing and blowing through treatments. Outcomes have not been good, even with using standard of care bispecifics. I think we need better strategies how to debulk this disease and use it better in the real world setting. And the last case I'd like to conclude and propose is a patient with follicular lymphoma with POD24 disease, got all the standard Rituxan, BR, R-squared. Would you give this patient CAR-T therapy or mosunetuzumab bispecific as the next line? And I'll start with you, Dr. Salles.
Oh, well, I think, there are many aspects. I mean, we have some CAR-Ts, and maybe with follicular, we have 2 CAR-Ts with different profile of side effect, and CAR-T would be a one-time treatment. if you use a 4-1BB CAR, T-cell is approved, but maybe tumor lyso-cell in this setting, it's easy. Patients usually don't need bridging. You can treat the patient outpatient. So it's not the whole constraint or the whole concerns that you have with grade 3/4 CRS, grade 3/4 neurotox that you have in diffuse large B-cell lymphoma with CD28 CAR. So I think we should wait things for the patient. CAR T is a good option there. Bispecific is also a good option. I think there are pros and cons to both options, and I will each time discuss with the patient. I don't have a strict guideline. Maybe these patients that went through several lines within a short period will be, for me, a better CAR T candidate. But, again, if he was recently exposed to Benda, maybe I will go away and try to use bispecific. Many scenarios, patients with follicular lymphoma are all different individual patients.
That's an excellent point. Dr. Lunning, any other thoughts on how you tend to sequence mosunetuzumab and CAR T in your practice for this type of follicular lymphoma patient?
Yeah, I think in this situation, you could see me being that person at the circus who's trying to ride two horses at once, and then we'll jump off one, and decide which one to ride. Because it sounds like this patient's going to need therapy like immediately. And we've alluded to on prior segments about the brain to vein time. So your CAR T cell is not going to happen tomorrow. And guess what? I can get mosunetuzumab off the shelf, within the next week. Let's say that you get going on mosunetuzumab and they go into a CR. You can still be kind of talking to them about, CAR T, and then pull the CAR T cell plug and not apheresis the individual. And you've only wasted some financial, time a little bit, but not necessarily too much. Now, let's say that person is stable disease, right? Or you're not really deriving much benefit from the mosunetuzumab. Then you could hop and be the jockey on the CAR T and just roll right into it. Now, I know there's not a lot of data on that, and I think that everybody's going to have the question about, can you manufacture? What's the T cell fitness going to be? But again, that patient's progressing on a bispecific. So what else do you have? There are other therapies, granted, in relapse refractory follicular lymphoma, but probably CAR T cells still the best option for that patient in this scenario. That's how I would kind of play it out.
Absolutely. Those are excellent points. I think it's great that our patients have lots of options in today's age, and with bispecifics and CAR T cell and novel agents, I think the future has never been brighter for B-cell lymphoma. So I'd like to conclude this segment. Thank you again for joining us for this segment on optimizing therapy with bispecific antibodies. Please be sure to click on the landing page for this activity to claim your AMA, ANCC, ACP credit, access supplemental slides, as well as other topic segments and case scenarios. Thank you.